Good morning. I am substituting for Dr. Rajan so that the program continues. I'll present today on non-cirrhotic portal fibrosis mainly, and I'll try to simplify but update you till yesterday what is in this area of interest. So it was way back in 1883 that we had the famous Dr. Benti, who published in Florence, Italy, what he called as del anemia splenica. And by this he really meant that there is anemia and there is splenomegaly, and subsequently it came out to be what Benti's disease was. So this is the journey from 1883 onwards. So it was termed as Benti's disease. Then subsequently a term non-cirrhotic portal hypertension came in 1908. As early as that, then Whipple, the famous surgeon, said there is an intrahepatic block. In 61 there was a term of idiopathic pre-sinusoidal portal hypertension. Michelson gave the pipe stem or hepatoportal sclerosis, and then Hans Popper gave this term, which is very dubious, incomplete septal cirrhosis. Sheila Sherlock gave partial nodular transformation, and Jim Boyer, working in Calcutta, gave the term idiopathic portal hypertension. And this was the most important landmark work by ICMR, gave the term non-cirrhotic portal fibrosis, with Dr. Nayak leading it. And Ian Wanless gave nodular regenerative hyperplasia, and we gave non-cirrhotic portal fibrosis, non-cirrhotic portal fibrosis as pre-NCPF, and gave a unifying theory. Then idiopathic non-cirrhotic portal hypertension. Then Waldig, the vascular liver disease group, they gave the term, I will come to it, PSVD, and now in 2026 in Bavino 8, and very recently in the hepatology journal, the term of PSVD NCPF together. So what is this disease? It's a hepatic vascular disorder with characteristic histological features classified anatomically based on the site of resistance to flow in the presence or absence of portal hypertension. So the rise in portal pressure, that means portal vein, is more than 10 millimeter due to intra or prehepatic lesions in the absence of cirrhosis and Budd-Chiari syndrome. And HVPG is significantly lower than the portal pressure, and the good functions, liver functions, are good. So there are two types mainly. One is the extrahepatic portal vein obstruction outside of the liver, and one is non-cirrhotic portal fibrosis or portosinusoidal vascular disease. So this was the first consensus published in 2007, and it gave 5 characteristics. It is a venopathy of the small and medium portal vein branches, the inflow, and it causes development of portal hypertension. On liver biopsy, there is no cirrhosis. The splenoportal axis from the spleen and superior mesenteric vein is patent, and the liver functions are near normal, and hepatic vein pressure gradient is near normal. Over the years, several things came up. So let me first explain you what is a normal splanchnic circulation. So from the spleen, the portal vein forms, and it opens up into the sinusoids and is drained out through the hepatic vein. The portal pressure normally is up to 10 millimeters or so, and the wedge hepatic vein pressure is 6 to 12. The free hepatic is 2 to 7, IVC is somewhere around 2. So a gradient between the hepatic vein and the free hepatic vein pressure is less than 5. Means if you put a balloon here and you put a balloon in the free, the gradient would be 4, 2, 3. That is normal. In non-cirrhotic portal fibrosis and the alternative term idiopathic portal hypertension, you have If the balloon is placed or you measure here, the pressure would be 25. In the splenic vein, the pressure would be similarly high. Then the portal vein here would be high, and the gradient is much more. Here you will see that this pressure is here, but this pressure is not transmitted beyond sinusoid. So everything is before sinusoid. This is pre-sinusoidal. If you measure the varices, intravaricial pressure, or what we do here is direct portal vein pressure, or you measure in the spleen, the pressure is high. HVPG therefore is not useful. The gradient is lower. This is exemplified here. In the normal, the portal vein blood comes, the hepatic artery, the blood is joined here in sinusoids and it goes out. These are very thin tributaries or branches of the portal vein. Now in the non-cirrhotic portal fibrosis, this area is thickened, and also the sinusoids are partly thickened. So the pressure gradient is here. There is an increased resistance here to flow, which is transmitted back towards the side of the spleen. The second consensus came in 2024, again led by Asian Pacific, this time led by Dr. Akash Shukla, where now in 2024 we have clarified much more. Extrahepatic splanchnic venous thrombosis, portal vein, splenic vein is separate, and Budd-Chiari syndrome, which is beyond the hepatic vein, is separate. And these entities are excluded because they are independent diseases. Schistosomiasis, congenital hepatic fibrosis, pileosis, VOD, hypervitaminosis, and many others like this. And non-cirrhotic portal fibrosis now has three main subgroups. One is a group where you have idiopathic or non-cirrhotic, but the classical feature is of obliterative portovenopathy. Then you have variants, NRH, partial nodular transformation, or incomplete septal cirrhosis. In this consensus, for the first time, stages of NCPF were given. Stage 1, which we had described in 89, now is given stage 1. There is no portal hypertension. Only liver biopsy has features, which I will show you. Stage 2, probable portal hypertension, but it's not clearly documented. Uncomplicated portal hypertension, collaterals or varices, but no bleeding. And 4 is portal hypertension with complications. This terminology has been endorsed by nearly 285 investigators from Asia. Now let us go to pathology. Some of these are taken from previous publication. So one more time, spleen, splenic vein, superior mesenteric vein. If the block is outside the liver, this is extrahepatic portal vein obstruction. If the block is in the second, third, fourth order branches, this is non-cirrhotic portal fibrosis. If you take the veins inside the liver, these are thick and also muscular veins. And if you look into the detailed microscopy, you will find out that there is a portal, the area in the portal vein, these are thickened and there is thrombosis inside. So there is intimal thickening, and then you have neovascularization, new small portal veins open up around. These are neovascularization was long ago described. There is periportal fibrosis, and CTGF and MMP expressions are increased. And if you do the electron microscopy, the space of disc is filled up with collagen. These are not normally seen in a needle biopsy, they are seen in a wedge biopsy. Incomplete septal cirrhosis is a very vague term. It's actually somewhere in between normal NCPF to a cirrhosis stage. Here you have thin septa, incomplete partitioning, somewhere there is a nodule, there is a hypoplastic portal vein and rudimentary nodule. These are classical. And NRH is a multi-acinar regenerative lesion. There is an ischemia, hepatic ischemia, but there are no big fibrous septa. And these are all pathologists delight, but they see it very rarely. How do you diagnose non-cirrhotic portal fibrosis? So a patient normally, not on biopsy, normally comes with portal hypertension, splenomegaly, anemia and low platelets. So what you will do is liver stiffness today. If it is more than 10, you think it is liver fibrosis and maybe cirrhosis or advanced compensated chronic liver disease, and you evaluate. If it is less than 10, 6 being normal, and spleen stiffness is high, which is normally up to 32, you think there may be a patient with non-cirrhotic portal fibrosis. So you will do a portal vein Doppler. If it is showing cavernoma, it is extrahepatic portal vein obstruction. If there is no cavernoma, there is a patent portal vein. Then you will do an HVPG, which should be normal, near normal, that is 5, 6, 7, 8. And liver biopsy will show you features of what I have shown: obliterative portovenopathy, NRH, or incomplete septal cirrhosis. But there are challenges, and now the field moves in last 2 years. Is there a second presentation? So there is no second presentation, so I might take 5-10 minutes more to explain. So the whole world has diagnosed PSVD or non-cirrhotic based on obliterative portovenopathy, which was given by Dr. Nayak. But this may not be seen in the needle biopsy. And histopathology of non-cirrhotic may be seen, but you may have higher HVPG and liver stiffness. For all hepatology people, these are big challenges. These slides are provided to me by Dr. Chhagan. So this is a normal liver biopsy according to them, but portal veins are not seen so well. But otherwise they have diagnosed it as a, so in 30% of the liver biopsies, in the needle biopsies, portal vein may not be seen, and you will say, oh, this is obliterative portovenopathy, which is not correct. So Dr. Chhagan published this very important paper, which is not enough cited. Dissociation in hepatic vein pressure gradient means HVPG is high, liver stiffness is high, but histologically this guy has features of non-cirrhotic portal fibrosis. I hope you understand. Normally histology should also be normal, HVPG should be normal, and also this patient should have features of no cirrhosis. So when he classified these, he identified 6 such categories. One is obliterative portovenopathy. This is thickening of vessels, segmental subendothelial thickening, phlebosclerosis, as I showed you. Then he gave a new term, obliterative portovenopathy with bridging fibrosis. That is, there is fibrous septa which have come around. Of course, the other terms continued, incomplete septal cirrhosis, but this was the most beautiful addition. And then, does it have any clinical relevance? So here you will have patients who have got obliterative portovenopathy, but they have significant fibrosis. And this significant fibrosis, while others have normal, near normal HVPG, just simple obliterative portovenopathy, classical NCPF, but if you have fibrosis around, the portal pressures increase. And then the clinical outcome in these patients are also different. Here you have venopathy with fibrosis, and here you have OPV. The green line shows you that those obliterative portovenopathy with fibrosis have worst outcome over a period of maybe 5-6 years. They have further worsening. The stage progression occurs in them. And these slides also provided by Dr. Chhagan is to see that here in the empty stain you have probably attenuated portal veins, and here actually you hardly have any good portal vein. In this one you have bridges which are seen, and they are thin septa, thin bridges are seen, and sinusoidal fibrosis. When you look at it, you will immediately say, well, it could be cirrhosis, but no, these are obliterative portovenopathy with fibrosis, and they have higher HVPG portal pressure than those without fibrosis. So this is something new which we are learning. Now the other 3 challenges are: patient has decompensation, he comes with ascites, and he has sometimes diuretic refractory ascites, but you do a biopsy, there is no cirrhosis on biopsy. So we keep asking, have a relook at it. They say, sir, no biopsy, this is normal liver, nothing else. So the relevance of this is liver biopsy can miss diagnosis of cirrhosis in up to 30%. This is a sampling error you may take from this area which may not show, or this area which may show. The second is portal vein thrombosis can develop in non-cirrhotic portal fibrosis. There is always a resistance, portal pressure is high, and over a period of time they can develop, and this occurs in about 15% of the patients over time. Say you see a patient when he has got portal vein thrombosis, you will say, oh, he is portal vein thrombosis, but if you have gone back in time, for 10 years he was having non-cirrhotic and now he has developed PVT. Compared to cirrhosis, non-cirrhotics have 3 times higher portal vein thrombosis. And lastly, you have a patient who, let's say, autoimmune liver disease, but he has features of non-cirrhotic portal fibrosis. And here is such a patient again provided. She is 31-year female, ANA positive, high IgG, and AST ALT are high, grade 1 varices, HVPG is 11. And this is a patient which, if these details were not given, could have been diagnosed as non-cirrhotic portal fibrosis. No portal vein seen, hair thick portal vein, but this patient has probably autoimmune hepatitis where features like NCPF are there. So there are diagnostic challenges, and these 5 I have listed. This is what I presented in the Bevino 8 conference to highlight that first, biopsy is necessary, but biopsy may not be adequate. Second, you may have an underlying liver disease, let's say alcohol associated hepatitis, and have features. So we are still in difficulties. Let's go further. So this was 2007, this was 2024, and this is 2026 accepted article, which we do not totally agree. This is a multi-society consensus statement in PSVD or NCPF, and I want to tell you the history. For last 2 years, the world was decided, they were concluding that there is no term as NCPF. They only said there is a term called PSVD, portosinusoidal vascular disease. It took us all our efforts to say there has to be NCPF, because NCPF is the original term for ages. PSVD is a term designed by the European group of experts. So now let me bring you what this paper in press is showing, portosinusoidal vascular disease, the diagnostic criteria. The classical criteria which were there have been changed. The term NRH, which we rarely see, they have changed the portal venule to a muscularized portal venule. It means there are some muscles which do not normally would be seen in a needle biopsy. Thirdly, obliterative portovenopathy, which was the basic, has been changed to portal venule stenosis of more than 50%. Say you are seeing 4 portal tracts and one is there, what will you do? It is again going to be a challenge. Second, the word stenosis is for a short area, and this is a defined term, stenosis partial complete. So this is again a challenge, but this is what they have accepted. They have also accepted minor criteria, regenerative changes without clear NRH, abnormal distribution of vascular structures, there is closing up of the portal areas, and portal venule stenosis of 25% to 49%. How much can be agreement between 2 pathologists, we do not know. Anyway, if you have all 3 minor, again it is a PSVD, or you have 1 major, it is PSVD. So they further classified the portal hypertension criteria, specific and non-specific, GI bleed, varices, portosystemic shunts, and spleen stiffness above 40. Now this again is a challenge. Spleen stiffness may not be able to measure in all patients, and also if there is a portal vein thrombosis in between, then the spleen will be congested and the spleen stiffness can go very high. So any one single criteria will give you a diagnosis of PSVD. So again there is a challenge here. And non-specific criteria, ascites, varices, low platelets, splenomegaly, are also there. So now how do you diagnose PSVD/NCPF? We don't say, but they have put it in this paper. So you have signs of portal hypertension specific. So one sign, let's say spleen stiffness, you get 3 marks. Histological lesion, any of these, you will get one major. Just you have portal venular stenosis, you get 5 marks. You have conditions to be associated with PSVD. Let's say you have autoimmune disease, or you have the other conditions, rheumatoid and others, you get 1 mark. And if you have concomitant cause of cirrhosis, for example PBC or so, you lose 1 mark. So anybody who has got 5 marks is PSVD or NCPF. Meaning thereby, let me give you an example. If I have a patient with a spleen stiffness 45, nothing else, he is diagnosed as PSVD or NCPF, which may not be correct. Or on the other hand, if you have just muscularized portal venule or NRH, you will go into these things. So to summarize, PSVD diagnostic criteria are not fully applicable to what we know as non-cirrhotic portal fibrosis, and therefore I thought, along with others, 2 people, that further harmonization is needed. So this was a result of the meeting they held in 2025 December, and we wrote a piece for gastroenterology which came last month in February, March. And this was that NCPF, IPH, PSVD, from debates to future directions. This diagram, which was created by Dinesh, and we termed this as inflow vascular diseases. Inflow, there are outflow diseases and there are inflow diseases. So what are inflow vascular diseases? Let us start. So the first is an endothelial injury which occurs in the branches, 2nd, 3rd, 4th order branch of the portal vein due to probably pathogens, toxins, drugs. So they all travel in the portal vein and they will cause an injury into the endothelium. This endothelial injury, nitric oxide, TGF beta, and the transformation, the endothelial to mesothelial transformation, iterative portovenopathy, and in this you will see that you have neovascularization, you have endothelium which has got thickening and thrombi present, and there are aberrant portal venules which are seen, and there is an arterialization of the portal vein. This is classical OPV. Because of this, there is a type 1 collagen which deposits around the portal vein. This is periportal fibrosis, which is another classical feature of this. Now, as I said here, the endothelial injury, the liver sinusoidal endothelial cells convert to mesenchymal cells here, and this also extracellular matrix remodeling occurs through TGF beta. This is what finally ends up that you have at the end of it a situation which I said there is a pre-sinusoidal thickening and there is also perisinusoidal thickening. Long ago in 1987, we described 2 gradients. One gradient is here, which is a pre-sinusoidal gradient, and one gradient is here between this and this area, pre-sinusoidal to sinusoidal. This was called a perisinusoidal gradient, and these 2 gradients qualify based on the histology. I hope I made it clear. So this is the pathogenesis. The several consequences of this can also occur onto the hemodynamics. There is also a group of incomplete septal cirrhosis. I told you thin septa which are not complete, and also portal vein, there is a hypoplastic portal vein. This all leads to a rise in intrasplenic pressure. There is increased eNOS production and iNOS production. It can also lead to NRH here. Now, common causes for this inflow vascular disease, NCPF, are infections and inflammatory mediators. So, infections and inflammatory mediators. Hematological and prothrombotic disorders can also cause drug-induced injuries and genetic mutations and disorders. And this diagram beautifully gives you stage 1 where the portal pressure is 5 or less. So there is no portal hypertension. As the time or the disease progresses, you have stage 2, 3 and 4 where portal pressure here increases but not on the outflow side. So these are vascular diseases, and we thought we can put them onto same platform of NCPF and PSVD. How do you manage these patients? Before that, PSVD, the term given by the Western group, includes portal vein thrombosis. We do not. Decompensation means patients are presenting with ascites. In this paper, subsequently we do not agree. And MELD score, which is used for cirrhosis, is not used for NCPF. However, we are merging towards newer areas. I'll show you that. And this was also by Dr. Lose from Germany, who strongly, along with others, feels on this. So what are our treatment options? Identify the cause if you can. Let's say there are infections or there are other drug-related things, remove them. Our aim is to prevent fibrosis, rise in portal pressure, anticoagulants, endothelin receptor antagonists, statins, and prevent endotoxemia. Now the natural history of NCPF and stage migration. These are new areas. So this diagram was created by Dr. Babulal beautifully for one of our review articles. So first is increase portal flow, hyperdynamic circulation. I showed you previously endothelial injury into the portal venules occurs. There is an obliterative portovenopathy, the volume is decreased, collagen is deposited, and there is periportal thickening. So the natural course is patients clinically present to us, clinically to a doctor, splenomegaly by the age of about 20 years or so. Then over the next few years or so, splenomegaly, hypersplenism, varicose bleed, they start occurring. Patient gets minimal hepatic encephalopathy, means he is not clinically, but he has obtended high quality work, and over a period of time these things worsen. By the 4th decade he may develop HE, he may get transient ascites, which is diuretic responsive, and hepatopulmonary syndrome. We need to see endotherapy, the partial splenic artery embolization or shunt surgery, and maybe there is a need in a few group of patients on liver transplant. Using Dr. Chhagan's work, which is to me a landmark, is that NCPF stages. So he gave us stage 1, 2, 3 and 4. Stage 4 is where you have complications of NCPF. So if somebody presents to us with a stage 4, you can see the mortality in about 14 years or so is high. But if suppose somebody has pre-NCPF stage, then you will see that they remain well and mortality in stage 1 and 2 is significantly less. So it is important for us to know any stage. So I request everyone, and this is only assumption, retrospective. Prospectively, are we correct or not? We do not know. So is there a stage based migration? So pre-NCPF and biopsy features are there. So there is only liver biopsy, no other features. So biopsy shows any of those features which I must describe. Patient may have raised AST, ALT. Since this stage is not described, there is a huge need of animal models because patients come to us with bleed. So how do you understand earlier stages? Only by animal models. Stage 2, probable portal hypertension is picked up by imaging. We can start non-selective beta blockers, anticoagulants we don't know, and treat the etiology. Uncomplicated portal hypertension, that is, patient has features like varices are there is collaterals. You will start maybe primary prophylaxis by non-selective beta blockers, which we showed long ago, that non-selective beta blockers are effective in NCPF, and we do not know the role of anticoagulants. Now stage 4, those portal hypertension and complications where variceal bleed, ascites, MHE, refractory ascites, massive bleed and prevention of portal vein thrombosis are our aims. We can do for treatment of hypersplenism lineorenal shunt, but prophylactic shunts have not been found to be useful. For refractory ascites, which occurs in about 5% of non-cirrhotic, we have to find out different options. And these could include TIPS, PARTO, or maybe even liver transplant. We do not have enough data for this. So, as patients present late to us in stage 3 or 4, we need good animal model. And I started my career developing these models right from 1984. And my mentors included Kunio Okuda, who is the father of hepatology. I don't know if you can identify me. And this is my another mentor, Roberto Grossman. This was Yale in 1988, and this terrorist looking is me here. So these are two who helped me develop the models of non-cirrhotic portal hypertension. Kunio Okuda had developed a model of E. coli and anti-E. coli. So he used to have E. coli, put it into the rats, and then get the anti-E. coli or into the rabbits, and then used to mix them, and these used to be big proteins. So my debate in my mind was, if you give such a high big protein into the portal vein, it will cause ischemic injury more than the injury due to E. coli. So I changed this model later on to pure E. coli model into the portal vein, but before that developed the schistosomiasis model in murine model, umbilical sepsis model, the murine chronic arsenic feeding model. Splenic extracts were taken out and given directly to the through the portal vein or superior mesenteric vein into rabbits and rats. We developed an LPS model, and this was very interesting, a rabbit, rat and gastrosplenic vein, and then endotoxin induced portal hypertension. To me, the best model is endotoxin induced portal hypertension. Why is it? Because we have, this is a rabbit, and in the rabbit we put through the neck a catheter which goes into the gastrosplenic vein, and this catheter stays for about 6 months, and we keep it patent by heparinization, and through this catheter we keep injecting E. coli slowly over a period of time, and this continuous chronic endotoxemia leads to development of portal hypertension. Portal pressure increases, mean arterial pressure goes down, which is a feature of portal hypertension, splenomegaly with normal LFT and normal histology, and all these protein works had been done. To this, in these animals, if you see, in 1 month time compared to sham operated, the non-cirrhotic, there is a rise in portal pressure, and this portal pressure is maintained for 6 months as long as we keep injecting endotoxin. There is a splenomegaly and arterial hypotension and no significant fibrosis with portal vein occlusion. And the second part, another thesis, PhD thesis, these are all parts of PhD thesis. Probiotics were given and they were able to reduce portal pressure and in the animals, and then also a human study was done by Dr. Nitin and published in Liver International. So the idea was that animals or human beings with chronic endotoxemia can give you endotoxemia induced portal hypertension, and the site of resistance was the HSC stellate cells. And this was the first work which I did with Roberto Grossman at Yale. So this was a model of schistosomiasis. So if you give the animal schistosomia infection, by 5 weeks they start having rise in portal pressure, and by 9 weeks they develop collateral. So we decided we will give these animals propranolol at week 5, and those animals who received the propranolol at week 5 had lower portal pressure, lower portosystemic shunts, lower portal venous inflow, and no hepatic artery reduction. This was the first experiment, and This was published in JCI, and this is the basis for all work of beta blocker for primary prophylaxis. All studies subsequently used this animal model. And just to give you an idea, these animals were developed in Boston, in Tufts, and they were flown in by a helicopter, and they would land into the tennis court where I used to pick these animals and work on them. So I always used to think animals before sacrifice have a helicopter ride. How do you manage non-cirrhotic portal fibrosis? If the patient comes with acute bleed, standard therapy. Uncontrolled bleed, standard therapy. You can sometimes have a PSRS if you have a very good surgical team. Pure splenectomy should not be done. For preventing rebleeds, beta blockers can be given. And this is what we showed in that study, that beta blockers are as good as EVL. So you can have like cirrhosis in non-cirrhotic, giving beta blockers for long can prevent rebleeds. Also, if the patient has hypersplenism, you might do a shunt or partial splenic artery embolization. And if there is a partial portal vein thrombosis or you are worried, then you can give anticoagulant, but no data. And pregnancy in these females are normal, and you can do prophylactic band ligation in them. Now, some new areas. Tips in PSVD or stage 4 NCPF. We have no data in stage 4 NCPF with ascites of tips. But the PSVD, what the Europeans do, they have done 170 such patients, and in them they said that in tips arm there is some benefit, and they have done close to 170 patients. The indications were bleeding and ascites, but post bleed, post tips they had development of HE, and the survival was 80% at 2 years. So this is an area we do not know, but let's start doing staging of NCPF and see. Also, liver transplant has not been done. I know two patients we have tried. PSVD liver transplant cohort is about 120 to 150 patient. Data is not clear. Refractory ascites, HE, HPS were the main indications. But some of them could be wrong diagnosis because they could be underlying cirrhosis. And survival is good in these patients. I'll come back to this diagram one more time just to say that stage 2, 3 and 4 are important for us. All of us we should try and see if the staging is helpful, and whether, because this is ahead of what the current hepatology paper says. So my carry home message to you that all these are new messages, and all those who have worked for non-cirrhotic portal fibrosis or portal hypertension, these areas are now exciting. Still do not know what is the etiology, how does the disease occur. So non-cirrhotic portal hypertension is the umbrella term. It has NCPF, which I have described. I have not purposely tried to say extrahepatic portal vein obstruction. And of all the patients who come as bleeders, I do not have data because I only came to know yesterday about absence of Rajan from this. So, but we do have data from past. 10% of all bleeders are non-cirrhotic, and I think the better term is an inflovascular disease of small portal veins, and this has obliterative portovenopathy with or without fibrosis. The HVPG and normal, and liver functions are near normal. LSM less than 10, SSM above 50. The Westerners say 40, I think 50, and we should do the staging. Survival in stage 4 is poor, and we should see that we can do stage reversal, stage 4 to 3 or stage 3 to 2 if possible. We therefore need trials with anticoagulants, endothelin receptor antagonists, probiotics, antibiotics, and many more. PSVD is over-inclusive. It includes all diseases. It includes people who have got alcoholic liver disease, who have got autoimmune hepatitis, and if they have a feature of liver biopsy, they will diagnose PSVD, which I don't think. They will also include portal vein thrombosis, which is also not correct. They also include decompensated cirrhosis and use MELD score, which is only used for cirrhosis. So I'm just trying to say my thinking probably is the only lone voice in this area, but I stick to my curiosities and thinking. So I think PSVD is not a correct, it is over inclusive. So I think still non-cirrhotic portal fibrosis the way we have described, and I would like my colleagues and fellows to test this. And EHPVO occurs in children, bleeding, growth retardation, and in adult biliopathy and ascites are the main things. So I do hope what I presented in Bebino, I have modified this with the new paper, and I hope I have given you some clear messages. Thank you for your attention.